So hello everyone and welcome in this doubt clearing session on your best online uh, channel, that is Dermatology Pearls by Dr. Chesta. Now can you all give me a quick thumbs up if you can hear me properly? Just give me a second, let me check if my audio video is all coming fine. Everyone can give me a quick thumbs up if my audio video is fine. Amazing. So welcome in this dermatology session where I will be discussing a lot of doubts from all the students. Can I get a quick thumbs up from all students if everything is fine, my audio video is all clear? Okay. So let's start with the doubts. I want all my students to kindly start posting their doubts here. Before starting the session, let me introduce myself. I'm Dr. Chesta Agrawal, your NEETPG educator. I have a 7-year experience of teaching all the pre-PG exams for all the pre-PG exams like the NEET, even the exams like FMG, and recently we have a 100% strike rate in all the exams. So let's start with the today's doubt clearing session. Now I will be discussing some of the important doubts which students have already asked. And if you have any doubts, you can keep posting on the chat section and I will answer your doubts as soon as I get them. So the first doubt which I got from the student is, the question was, in which of the following condition parakeratosis is most frequently seen? This is a PYQ. We already got this question in the past. Please remember, all of you, parakeratosis means there is presence of nucleus in the cells of stratum corneum. Now what happens, normally the only layer which has the capacity to divide, the keratinocytes have the capacity to divide, is the stratum basal layer. So the cells of stratum basal have the capacity to divide. After division, it slowly moves upward, it reaches to the stratum spinosum, then it goes to stratum granulosum, lucidum, and finally stratum corneum. Now as the cell progresses from the lower part to the upper part, two things happen. One, there is change in the shape or morphology of the cell. Second very important feature which develop is there is loss of intracellular organelles. But there are a few conditions where the intracellular organelles are not lost, and one of them is retention of the nucleus. So you see retention of the nucleus, which is known as parakeratosis. A very common example to that is psoriasis. But please remember, even actinic keratosis is a condition where you have retention of the nucleus or parakeratosis, like that of psoriasis. So that was the first question which students have posted on the group. So that is actinic keratosis. Moving to the next question, I want all my students to kindly answer this question. The question is, this is a leprosy question. Again, it's not a new question, it's an old question. Can anybody tell me what is the correct answer? In leprosy, which of the following is not seen? In leprosy, which of the following is not seen? Anyone can tell me the answer here? Very nice. The correct answer of this question is, what is the correct answer of this question? The answer is, you will never see changes in the proprioception. So what is leprosy? Leprosy is a condition in which the nerves are affected, mainly the peripheral nerves. Now peripheral nerves has mainly two roles. One is sensory and another is motor. So because of sensory loss, you will see that there is decrease in the tactile stimulation. There is a decrease in tactile sensation. But why there is increase in the response or increase in the tactile sensation? Please remember, all my students, this occurs in case of lepra reactions. This occurs in case of lepra reaction. What happens during the lepra reaction? Patients suddenly start developing, there are sudden increase in the inflammatory mediators which stimulate the free nerve ending, causing even an increase in the sensation. So both things can happen, decrease because of damage to the sensory component, and even increase in the sensation, which can be seen in these individuals. Okay, so both these things can be seen. Now why there is change in the muscle? This is because of the motor function. And what happens in the muscle? You will see disuse atrophy. Please remember, you develop disuse atrophy in the muscles, and that give rise to voluntary muscle weakness and abnormal electromyography. Okay, so both these features occurs because of this. So the only incorrect statement which is not seen is proprioception. All the fibers which are carried through the posterior column of the spinal cord, like proprioception, stereognosis, vibration sensation, they are intact in the patients of leprosy. So that was the second doubt which I got from the students. This is the third doubt. I want all of you to please answer this. What is the correct answer of this question? Patient with single anesthetic hypopigmented patch on the forearm. What is true? A patient with single anesthetic hypopigmented patch on the forearm. Now again, it's a very interesting question from leprosy. Now WHO, what WHO has done, WHO has divided the patients into two broad categories so that we can easily treat them. One is the paucibacillary group and another is multibacillary group. So WHO have divided the patients into two groups. Paucibacillary are those where the skin lesions is 1 to 5, or if the nerve is involved, it is single nerve. While multibacillary are the skin lesions which is more than 5 obviously, and if the nerve is involved, it should be more than equals to 2. So if either of them is present, then it is multibacillary, and if either of them is present, it is paucibacillary. For treating paucibacillary, we give 3 drugs: rifampicin, clofazimine and Dapsone. The duration is 6 months. While for treating multibacillary, the drug is same: rifampicin, clofazimine and Dapsone. The only difference is you have to give the treatment in multibacillary for 12 months. That is the only difference you will get. Okay. Now please read the question. In this single patient, you will give a single dose of rifampicin, ofloxacin and minocycline. Is it true? No, you have to give all the 3 drugs. So please remember, the first question is, or first option is wrong. Second, if it is left untreated, the patient of paucibacillary rarely develop into any side effects. So if it is left untreated, then please remember there will be no sequelae. Serology PCR is required for diagnosis. We have just now seen that it's a pure clinical diagnosis, so that is also wrong. The only correct statement is you have to give 6-month therapy with Dapsone, clofazimine and rifampicin. Clear everyone? Very easy, very simple question. Any doubts, please post on the chat section. The next question, again, a lot of students have seen they have confusion in this particular question. Few mark option number 1, few mark option number 2. So what is the correct answer? The drug of choice of ENL in a post-menopausal women. Very commonly asked questions, and I have seen that students are being confused on this particular group. Anyone can tell me the correct answer here? The drug of choice for ENL in a post-menopausal woman. What is the correct answer? Very nice, all my students. Please remember, if nothing is given, just imagine if nothing is given like this. The drug of choice for ENL, the answer is steroids. But look at this question. The question is mentioning something else. Why we are not giving thalidomide in a patient of type 2 lepra reaction? The only reason was the side effect of thalidomide, which is teratogenicity. But if the patient is already post-menopausal, she is not fertile, so the risk of teratogenicity is gone, and that is why instead of giving steroid, you will prefer thalidomide, which is anyway the most effective drug. So please remember, the drug of choice for ENL in a post-menopausal woman is thalidomide. Clear all of you? Very easy and a very simple question. This is, I think, again, many students have posted this. So what is the correct answer, everyone? The doubt clearing session. So the students are posted the doubt on the group. Anybody else have any doubt, they can just ask here, they can just post it here. Amazing. Now we have 2 type of classification system. One is Reedley-Jopling and another is Indian classification. These 2 are more popular. We have other classifications also like WHO, Madrid classification, etc. Now Reedley-Jopling classification, it uses 4 criteria: clinical, bacteriological, immunological and histopathological. It uses 4 criteria to classify the patient into leprosy patient. So it uses 4 criteria for classifying the patient into leprosy. But what about the Indian classification? Now please remember, in our country, in our setting, it is not possible for us to keep the good infrastructure with a qualified dermatologist or a leprosy expert at the grassroots level, that is the village level. It is not very much possible. So what happens? We have designed our classification system in such a way that we only require one criteria, which is clinical criteria, to classify the patient into the different subgroups of leprosy, like lepromatous, like tuberculoid, like borderline, like indeterminate, or pure neurotic. So that is the difference between the Indian classification as well as the Ridley-Joplin classification. So these are the very important differences. So welcome fanboy, welcome to the class. So this is a doubt clarification session, and the doubts which were posted on the group, I am here to just clear the query. If you have any doubt, you can just post it here. The Ridley-Joplin classification for leprosy is based on which of the following parameter? The correct answer is option number 1. While Indian classification, which classify the leprosy patient into these 5 types, it is based on the clinical classification system. Moving to the next question, I want everyone to answer this question. Fanboy, can you answer this question? An 8-year-old boy from Bihar came with symmetrical juicy papules nodules with hypopigmentation on the face and trunk. There was no hypoesthesia, the nerve thickening was not present. Fever was there few years back. What will be your likely diagnosis here in this patient? What will be the likely diagnosis? An 8-year-old boy from Bihar with symmetrical juicy papule nodule and hypopigmented lesions. Now here there are many students who got confused with lepromatous leprosy. They thought that this could be a patient with type 2 lepra reaction, because the type 2 lepra reaction you usually get presence of juicy lesions, that is nodular lesions. But please remember, the next thing which is given is there was no thickening in the nerve or any hypoesthesia in this particular patient. Plus look at the age of the patient. So please remember, this is a very very characteristic example of post Kala Azar dermal leishmaniasis, and you are absolutely right. The correct answer of this question is option number 2. Now this is a disease which occurs because of the bite of the sand fly. Please remember, leishmaniasis, it is a disease with a multiple of symptoms. You can get a pure cutaneous type of lesions which is known as cutaneous leishmaniasis, where you get very classical lesion which is known as Delhi boil or oriental sore. Even volcano ulcer is the name given to the pure cutaneous leishmaniasis lesion. What was the next thing? The second type is mucocutaneous type of leishmaniasis. In mucocutaneous variant, we were getting the lesions both in the mucous membrane as well as on the skin, and this was Chicklero ulcer and Ispundia. That was Ispundia, Chicklero ulcer and Ispundia. The next was visceral leishmaniasis, which is known as Kala Azar. Visceral leishmaniasis, which is known as Kala Azar. And in few individuals, after recovery from Kala Azar, maybe 2 to 3 years after that, patient was developing hypopigmented lesions as well as juicy symmetrical papule, and this is known as PKDL. So the correct answer of this question is option number 2. This is another question which I have seen students being confused. So please tell me the answer. What is the correct answer of this question? Anyone? Fanboy, can you tell me the answer here? The main cytokine involved in the erythema nodosum leprosum reaction is, what is the main cytokine which is involved in erythema nodosum leprosum reaction? Anyone? Very nice, amazing all of you. Please remember, the main cytokine which is involved in erythema nodosum leprosum reaction is option number 3. It is the TNF alpha. And please remember, because TNF alpha is the agent against which thalidomide works, and that is why thalidomide is considered to be the drug of choice for, not the drug of choice, the most effective drug for type 2 lepra reaction. Because of its lot of side effect, we are giving steroids or we are considering steroid as the treatment of choice. So thank you all of you. It was a brief session with some of the doubts. I request everyone to please keep on posting the doubts. You can download the app, or you can let me share my YouTube channel as well as my, you can post the doubt here. You can join my Telegram group. The name of my Telegram group is Dermatology Pearls by Dr. Chesta. Dermatology by Dr. Chesta. You can even join me on the Instagram, that is Dermatology Simplified by Dr. Chesta. I request everyone to kindly start posting the doubts so that we can make more and more such interesting videos. So thank you.